So now I have the great pleasure of introducing Professor George Kernahan, Professor of Health Research in the Institute of Nursing and Health Research in Ulster University.
Might need a slight adjustment here. Okay, research topics in symptoms in advanced dementia. What? Can you hear me at the back? Good. So, setting the scene for symptoms and looking at some specific examples. That's a little bit whistly at my side. Is it okay? Just keep going? Okay. I'm going to give you a brief background to the work as I come to it from work that I've done in Parkinson's disease, both in the north and then with Suzanne here in Cork. Trying to bring that in, adding dementia to the Parkinson's pathway, and then doing something called metacognitive modelling, which is to help me and help all of us, I hope, frame some of the complexity that we've been discovering as we've been working through this morning. This seems to be becoming a very complicated story, so I've got some models that might be able to help us to think about our thinking, which is what metacognitive models do. And then to get a little bit more practical at the end, I'm going to use the James Lind listing of priorities and the All Ireland Institute adjustment to those to seek some specific research priorities. And then for next steps, I think the idea is it's back to you to help inform the next steps. So my initial piece of work, or my initial minute or so, is to explain something of the difficulty over neurological linkage with palliative care, giving it a north and south perspective. Summarising very loosely and broadly, the palliative care provision in the south appears to be limited, and the services just aren't there for people that need it in neurological conditions, broadly speaking. In the north, the services are somewhat more available, but there's an inbuilt conservative resistance to using them. So there's slightly different sort of perspectives. In the north, we're still reluctant to accept the bridging or the linkage between neurological conditions, dementia, and palliative care. They're not coming together. I did this work exploring palliative and end-of-life care, and I found there was a lack of communication, a resistance really more than just a lack of communication. Palliative care is not yet, not for me. It's for the cancer people. It's not really for us. There was a fairly clear negative perception there. And then linking with what was going on here in Cork, the survey and the work that was done with Siobhan seems to show that there's something of a similar problem, but more based on a unmet need. So perhaps even in addition to the negative perception, the provision of the services leaves something to be desired. And as you see in your pack, that led to the work on the guideline, and I had a little part to play in that as part of the steering group that drew up those guidelines that have just been released. So that's the background that I'm bringing in to try to understand how to make choices about symptoms to focus on for research purposes. But not only in Parkinson's, we now need to add dementia. I think that's what I was asked to do, was to think about Parkinson's neurological conditions, adding dementia and looking at symptoms within that. When you begin to do that, then you start to think of the stages of the condition, from preventing it well, diagnosing it well, supporting people to live and then to die well. And all of that aspirational work, to do all of that requires us to work together. To do all of that well requires a joined up approach to not just to research, but to the clinical management, service delivery, the whole thing. So this is a challenge for us to bring people together to understand the pathway and to understand each of our individual roles. So that then leads me as an academic to analyse the way these concepts fit together and the framework that might help us to understand how the pathway can work, to include the different symptoms, to include the different perspectives. The challenging symptoms are here. I'll come back to them at the end, just so you don't need to be writing them down or anything, but you'd be familiar probably with them in terms of pain, and then put that on top of poor communication, the help we need with activities of everything, the activities of daily living, the appetite and the swallow, the ordinary problems of infections and pressure ulcers, as well as the mental health issues, and then on top of that again, the side effects of any treatments. There may be others that come to mind, and we've been speaking about some of them as well. So in order to try to organise that and deal with the complexity, I want to suggest this thing that I've come across from some years ago called Hodges' Health Career Model. This is probably the core thing that I can contribute here. And this is one of these Johari window things that divides up your thinking into boxes. I think it's of interest. If you start at the top of it, you've got the individual. Sometimes we have the individual at the centre, but for the sake of this model, think of the individual at one end, and then the path leads directly down to the group or the population. So at the centre might be the affected family, for example. So there's an axis that takes you down from the individual to the population. So that allows us to think of the public health perspective as well as the individual, and the whole dimension describes the people around the individual, the wider society, and so on. Then going across the scale from the mechanistic to the humanistic, we've been struggling a wee bit with this earlier. Can you see how this dimension takes you from the mechanical or the pure hard science, the pharmacology, the discrete interventions, the hard measurable scientific perspective, and at the other end of that dimension there's the humanistic side. Earlier we were trying to understand that the humanistic disciplines have a contribution to make. This model supports that as you go across it. Now, having set that up, you then have four components that are the sciences, the political perspectives, the sociological perspectives, and the interpersonal perspectives. That helps you to think about the whole of the career of someone as they might move through this. It's probably a bit hard to see how we might make practical use of this. It could be used as a mapping process. The difficulty in it is that it's really at a point in time, and you would have to think about how the journey goes for the individual or the people that are affected. So that then takes me to the more familiar sort of single dimension that you've probably seen before, which is the course of the illness. And this is where you move from left to right, from screening and diagnosis through the mixed curative and palliative phase in the middle, into an end-of-life phase, and then death and bereavement, all as a continuum. That's probably a helpful thing you've seen before, but the previous slide is intended to help with the more complex involvement of the different disciplines in addressing specific parts of this. Okay, finding research priorities within that theoretical view has been attempted by other people. So whilst that's a complex theoretical perspective, we're not needing to necessarily start with a blank page in terms of identifying points on those graphs. Something called the James Lind Alliance, that some of you may have come across before, have set particular priorities in palliative care that are worth looking at to see if it helps us to identify where dementia and neurological palliative care needs to look. The top is palliative care outside of working hours, and you can see some of the others there. Access, advanced care planning we've been talking about. Interesting how the things that we've been talking about feature on this list. I'm not going to spend very long on this because the All Ireland Institute have taken these and adjusted them for Ireland. So I want to move fairly quickly on to that. Page 2 of that. Anything there? Oh yes, there's I wanted to see if I could find something quite specific to Parkinson's disease. And if I go to the bottom of the slide, number 28 on the James Lind Alliance top 10 or the priority list is what are the best ways to manage the problems associated with difficulties in swallowing, including drooling and excessive salivation for patients with Parkinson's disease at the end of life. So there's some very specific research questions that an individual team or an individual site would be able to tackle, and others that are broader in scope that may require us to think about how we can address issues together. Okay, so the All Ireland Institute then worked with that list and reprioritised them in a process. So the top 5 are here. What are the best ways of providing care out of working hours? Still remains high on the list. Providing care in the patient's home. So system-oriented questions are important. What's the best way to provide pain and symptom relief? How do we best explain the dying process honestly and compassionately? And what are the benefits of ACP? And who should implement it and when? These are the questions that some of them we've been talking about already. 6, 7, 8, 9, and 10 are here as well. I'm not sure how useful these are right now. They're ways of identifying unique questions that other people have suggested that I suppose we could look at to find our priorities today. There's staff training. There's information. Number 9 is specifically asking us to look at non-cancer. So the next steps then are to identify which of these questions are appropriate for symptoms, work out which of them we might be able to take some responsibility for as individuals, which of them we need the network that we've just heard about to help us manage, which of them will involve a more theoretical perspective, which of them are more to do with service and service provision, and plan this in some detail. So this is the last slide. It's just rehearsing again. The challenging symptoms are pain, poor communication, activities of daily living, nutritional issues to do with appetite and poor swallowing. Other routine symptoms like infections and pressure ulcers that shouldn't be forgotten about, that happen in this area as much as anywhere else. Agitation and mental health issues, side effects of treatments, and then mapping those against the research priorities which have been set by other bodies are here in terms of achieving those symptom solutions in the context of people out of working hours, in the patient's home, offering pain and symptom relief in a way that I'm not trying to put all these together into one project, but you can see that there's a number of them that do link, and we may be able to challenge ourselves to try to ensure that the ideas we do take forward at least address the symptoms that have been identified and the priorities that have previously been set. So leaving those up there, I think the idea is that I look for your response to that as a framework, first of all, and then more specifically in terms of how you think that the resource that's in the room should begin to take these and look at the evidence that's already there in these areas and what we can do to bring them into the context of Ireland, both north and south. Is that okay? Thank you.
So now we're going to throw it open to the floor. Thank you very much, George, for an interesting presentation. So, yeah, I'd like to get your thoughts. Gentlemen.
Hi, Paul Galvin from the Tyndall National Institute. So we've been thinking about this, not done an awful lot except for things like pressure ulcers, but in a way, as I understand it, with a very limited understanding of the issues involved, what you need to do is be able to collect objective measurements of each of these, which inform the therapies, which can then be evaluated against objective measures of the improvements being delivered. So we need this closed loop capability. And obviously, in some cases with the residential care, you have a better chance to observe the effectiveness of the therapy. Where you're dealing with a home care, you have a more challenging scenario because you don't really know how well it's working. So there are some technology solutions that could be brought to bear, ranging from, we already have a project on pressure ulcers for remote monitoring, working with Fleming Medical on that, but we've looked at previously things like gastric motility, potential for a kind of a smart pill. So I'm not going to go into the details of the technologies, but there are potential technology solutions to objectively measuring each of those parameters that could be brought to bear. They're not trivial, they're not simple, but in principle, even taking them one piece at a time, they obviously have much broader implications than in this use case scenario as well.
Any other contributions?
Brian Lawler, St James Hospital. I just speaking to the model. I mean, I think there's a huge unmet need in the whole area of advanced dementia, advanced versus end of life. I guess we can debate really about the semantics of this, but in terms of agitation, mental health issues, in terms of how that's dealt with from a multidisciplinary point of view, and I think we're still really. Very, very poorly. Patients are very, very poorly served in this whole area, and you've had this in the hospital, at home, in the hospice. The treatments we've studied this very, very poorly, and we have very, very poor treatments, and the treatments that we do have tend to make patients worse. So I think there's a huge piece of work that could be done around this in this area. I mean, you can bring in technology and assist as well in terms of sort of the innovation, but I really feel very strongly this is a really important area to focus on.
Okay. Would you suggest a place to start in terms of where there is most likely to be a reasonable response? Which context would come to mind as a starting point? It's the Irish question whenever you're asking directions. Where would you start from? Would you start in a hospice setting where these issues are at least recognised? Would you start in the community? Would you look at an acute? Where would you? We would start with a systematic review and look at the evidence.
I think you start with the evidence and the systematic, but I think you start with the experts here. I think one of the what I've learned anyway here today is the different views of different individuals from different disciplines, and I think that we tend to get into silos in terms of how we think about these problems. I'm a psychiatrist. You deal with psychopharmacology, you tend to take that type of approach in terms of clinical trials, but there are people here with completely different perspectives. We heard about personhood this morning. So I think maybe if there was joined up thinking in terms of how to deal with this, not just one way or the other, but maybe in a kind of joined up holistic way. And it's, as I say, it is a huge unmet need, whether it's in the home, it's what causes great caregiver burden, distress, and people ending up prematurely institutionalized. But in the acute hospital setting, it's a major, major issue, and it's a major issue in nursing homes. And I think we do consultation into palliative care, into hospice as well, and it is a problem there as well in terms of how it's managed. I mean, I don't have any particular research questions. I'm just saying it's an area that I think if we focused on and paid attention to here with this the level of expertise in here, and including the science and the innovation, I think you could come up with really good research questions and research solutions, actually, taking this type of joined-up approach, which I think would be very different to what's gone on before.
Does anybody else
Suzanne?
think that we need to substantiate that? Or thank you.
Just one thing I was wondering, we in acute hospitals, we're moving very much to the idea of care bundles,
Yes.
where you have a kind of a checklist.
Yep.
And I'm looking at the challenging symptoms, and I'm saying, could we consider a care bundle for symptoms that we anticipate a person in advanced dementia is going to have? Because part of it is it's done sporadically. You know, sometimes a family will mention something, sometimes a staff member will think of it, whether really, no matter what setting we're in, if it's left up to us as part of our routine care, we miss symptoms. We don't even think of them, and if you don't assess the symptom, you can't treat it. And that's how care bundles work, because they bring everything up to a standard of saying, we anticipate that you should think about these 6 or 7 things. And as I look at that list, I wonder what other people think about a care bundle that you would say, we need to think about pain for the person in front of us and think, is this something we need to address? And literally go down through. So kind of like a check. I know it's a checklist approach, but equally to make people think, because if you don't think of, has this person pain, have they poor swallow, should I be checking for a pressure ulcer, and you leave it up to usual care, it will be sporadic. Some centres will be excellent, some people will be excellent, and a lot of people will have things missed. So I'd like to throw that out. Do people think that we could bring that idea of a care bundle to palliative care in dementia?
I've only ever seen it used in quite well-defined things like pressure ulcers. There's a skin bundle, and they seem to be quite narrowly focused. But I don't see why not. You should have a look. Have a look at what's been published.
Anyone else? Any thoughts on that? Care bundles?
I think care bundles are quite useful, and as Suzanne said there, it's good in relation to doing comprehensive assessment, but I think primarily it's listening to what the patient is telling you, what you're observing, and what the families are telling you. And I suppose working in assessment treatment centre, where we run community liaison support clinics and our day hospitals, and see what services and how accessible healthcare professionals are to this client group is really important, so that you build up your knowledge base around it. So I think certainly comprehensive assessment, so you're looking at like all aspects in relation to skin care, depression, mood, anxiety, but it's your knowledge of that person that's most important.
Thank you.
Gentleman behind.
How are you doing, Sean Kennelly? And yet again, just on the topic of care bundles, I think education and training, I suppose it's a common theme through an awful lot of what we discussed today. And how you get education and training which has a sustainable effect, because what happens, as we've all seen, is you do education and training, and unfortunately the effect peters out. And within this context, and particularly within the context of care bundles, the education and training of the person who's interpreting them, especially, as you said, in areas that are a little bit less described and less specific, is an essential part. And even that's a research topic. I mean, what is a good model for education and training? What is a good program for education and training, and how we sustain it? And I know many here have been involved in those kind of schemes the same as ourselves, but I don't think we clearly haven't cracked it, because it nearly always comes back to it.
Yeah, I think skin bundles have been used in training particularly. So whenever you've done the learning, you need to bundle less. So there's a bit of a link there between you devising a bundle, using it as training, making sure that it engages with the person themselves. So some of these things fit together.
Adrian Shalor again. I wonder if in developing a care bundle you have to explore the U-curve, which is that if you make the care bundle too specific, it becomes formulaic, or risks becoming formulaic, and if you make it too vague, it won't do much. And a useful model to think about would be the demise of the Liverpool care pathway, which was very formulaic and had and actually was then extremely heavily criticised for having been used in a formulaic way in its replacement with the 5 priorities of care, which think through the themes that should be thought through. So in other words, in developing things like this, it's around trying to make sure that the clinicians continue to think on an individual basis about individual patients and individual sets of needs, rather than saying, I know the solution for Parkinson's-related dementia, because actually there isn't a solution.
Yeah.
There's
Thank you.
about millions.
And just to add to that, the communication skills required to assess. So I think as people as their dementia advances, there is an additional skill required amongst all healthcare professionals to hone in their assessments, and not because they're not reliable on verbal cues.
Okay. So the development and testing of a bundle seems to be a possibility. Thank you.
And the training side on
Any other?
communications.
Yeah.
Other thoughts?
Joan McCarthy, UCC. I was thinking, and perhaps it's been done elsewhere, but the context within which we do things is hugely important, and our Irish context is hugely important. And I wonder, obviously I was saying earlier, you know, things are bad and things are getting worse and so on and so forth, but there are models of very good practice, of very good residential care settings where the cluster, where the educational training is rolled out, where it's all working. And do we know enough about those? Do we know enough about the features of practices that make them work? The kind of combination of staffing or leadership and or the educational interventions and where they are. Do we have a picture of that?
Because that's
And
where
so
you
it's a
would
bit
start.
like magnet
Yeah.
hospitals, but
Yeah.
you know, that kind of thing, something
Yeah.
like that.
Yeah.
That would be constructive and would give us horizons, but would also be contextualised, because you can have very good educational interventions, but if they're in the wrong place or they're with the wrong people or et cetera, then they don't work. So we need a combination of a number of things, and it's also positive.
Could I just add briefly the issue of chemical restraint? It is a serious issue which we see quite a lot. I don't think on its own it might be packaged within some wider study and research, but it certainly does need to be addressed, because it is the convenience medication of residents in nursing homes, in some nursing homes, is more widespread than people might imagine, and indeed in acute hospitals. So it might be added to your list in the context of some wider study. Thank you.
Hi, Mary Rabbit here. And I suppose I was just thinking about, you know, what you said earlier today, what people were saying about comfort and distress and agitation, and people with dementia and their experiencing of agitation. You know, what Brian said from James's Hospital. And you know, you were looking for research questions. And what I was thinking, wouldn't it be really nice to know what the lived experience is of anxiety or distress with dementia? And I know the difficulties of that with advanced dementia, but if you worked with people maybe in the early onset stages, it would give some very important information I think is missing, and maybe help guide what needs to be supported in care packages or whatever. But I think studying the lived experience of the person with dementia is very important.
Hi there, just to follow on, my name is Kieran Walsh, UCC PhD student, just following on there from what Mervyn said, that chemical restraint obviously is something that we're looking into as part of my PhD programme. So I'm looking into hoping to develop an intervention in a nursing home. So I'm hoping to encompass the public and patient involvement. So something that it is important, and I think it will prove interesting. So yeah, but I think a lot more research has to be done nationally and internationally as well. So that's just what I would say.
Thank you.
Any other contributions? Oh, Carmel?
I just want to say that it's not just in acute or in residential, because I had mum at home, and that's one thing they wanted to stuff her with, really. And because I wouldn't give it to her, they were annoyed. I didn't want her to be in a coma state, and I wanted her to express her own emotions and feelings, and if she was frustrated because she didn't speak for the last year of her life, so how could she express herself? And actually, you can express, you said 7 words there earlier. That's not true. You don't have to have any. Absolutely 0 words, and you can communicate. And my mom communicated with me to the last minute of her life. And people were in denial of that. And I'm happy to say that there was a geriatrician in Galway who came out to us one day, and he engaged with her for nearly 2 hours with no words. So it is possible, and there are medical people out there who believe it, but a lot of them want to give them these, whatever they're called, quietners.
I mean, seconding all of those things, but tying together what 2 people said, I think the lived experience is hugely important. I know we have issues around consent, but I think an awful lot could be done with observational studies around the lived experience. You know, we don't have to be able to articulate that we're anxious or that we're happy, or that, you know, we can communicate long before we have language. And so you could actually really do a very good study counting number of smiles or distressed facial expressions. And we were talking about that over lunch. I think there really needs to be a big educational piece around people working with people with dementia to understand that words are only one tiny means of communication. And in fact, most of us, words is only the smallest part of how we communicate. Because a lot of the time we know, you know, we don't say what we feel, but other people can sense things. And I just think that's a big educational piece that could advance things hugely.
Any other contributions?
I agree entirely with you there. And as you've said, even counting the number of smiles, or, you know, can we measure whether they're comfortable or not comfortable? I think what the challenge is then is trying to decipher whether it's pain or whether it's loss of appetite, whether, you know, it's progression of the, you know, what actual individual then symptom is it, because then that's going to lead you to a treatment pathway of some description. Yeah. It's just, that is one of a challenge that we're all going to face, I think, in this area, you know.
Great. So I'm going to wrap up this session. Thank you very much, George. And now...